Good afternoon, everyone. Thank you for the such a good opportunity. So I'm not going to talk about the all the statistics and paper about the advanced TRD. I think everyone is aware about this. So I'm just going to share one case, which is she's a 52-year-old female. She's one-eyed. She lost the other eye because of I think failed vitrectomy, and she has no light perception in the other eye. And she is very conservative. She presented to my clinic initially with hand motion vision because of very thick posterior capsular opacity, and she is very reluctant and resistant for anyone to touch her eye after the cataract. And I think this is because of the previous experience. I did for her YAG capsulotomy from the beginning. She improved. She gained around 20, 40 vision at the beginning. Then after, a time, upon follow-up, she has a deterioration of her visual acuity. And until she reached 2150, she is still, convinced that no one should touch her eye. Until I convinced her, I showed her the old, the new OCT and photos before and after the follow-up, and eventually she decided to go for surgery. She has a very ugly detachment, and this is what we see in daily basis in our region due to a lot of cases of diabetes with late presentation. You can see we are dealing with a monster inside the eye, so it's an elephant sitting inside, very adherent membrane. And of course, the retina is very thin, and you have to be very careful in order not to cause a break in her only eye. I was, going inside and with full hope that I will end the surgery without any break, so I will leave here just only with air. You can see once the membrane start to contract centrally, it will cause like retinal folds on the side. This is the area where you need actually to use the forceps to detach the stump from the disc. You may encounter some bleeding at some point of time, but you need maybe to just raise the pressure and control the bleeding. Pulling of those membrane is sometimes mandatory just to pull them off the retina. Then you need to manipulate with your cutter, back and forth, find any cleavage. And believe it, I'm just using 23 gauge. I'm not using even 25. But if you have the right plane, the right time, you may be able to deal with those cases. Again, forceps is very important to create like a small cleavage or opening. Then you can introduce your cutter to finish the job. Once you deal with very adherent membrane, I think it's time to use a second hand to support with bimanual. Here you can see me. I'm trying to dissect all the membrane. Some of them are still active, and you can imagine this case is after anti-VEGF injection, which was given 3 days before the surgery. Again, you have to be very patient. Roaming around the membranes in order to finish the surgery without complications. This is again the cutter helping to dissect, like a blunt dissection. We are almost at the end, dealing with the last membrane, and most of the time you lose your patients at the end of the surgery and where the complications start to happen. Luckily, until now, I'm just holding my self together, removing all the membranes, and this is maybe the last few pieces has to be peeled off the retina, and now we are dealing with the other side, so it's almost enclosing the macula from both sides. Once you are done with these membranes, now it's time to I think to stain the vitreous and see if there is any vitreous scared, and if, for sure, usually, can I just have it? I'm almost finishing, yeah. This is where I'm just controlling the bleeding. Now I have found like almost a new hyaloid underneath the previously scatic hyaloid and thick membrane. I lifted her with only air, and luckily she regained around 80 vision, and I'm following her almost for the last 3 to 4 years. Thank you.
Thank you, Dr. Mohamed. Very nice and elegant surgery as usual. Dr. Ahmed, you have any comments? I know you do mainly, you don't like to do bimanual many times, or this is, yeah.
I have to say that this is a wonderful surgery. I usually aim at doing such a complete surgery like this, and I end up without internal tamponade. Just leave the case like this. Patients will improve much better than leaving any tamponade, even air. The subretinal fluid will be absorbed gradually, and the vision will improve. Excellent surgery.
Thanks, Dr. Mohamed, for this excellent surgery. Yes, in cases of traction detachment, especially on the nasal side, I start from beginning by manual surgery, my hands.
So, in your opinion, bimanual surgery adds advantage to the unimanual, or you can do such tough cases altogether with unimanual? And let me ask you an inverse question. What are the disadvantages of bimanual? Why, if some people have the bimanual surgery and they do not opt to use it?
If you have an access to go for bimanual surgery, in every case it is well and good. But in my clinical practice, I start by manual surgery in case of tractional detachment involving the nasal side, and in case of combined traction rheumatology retinal detachment. Other cases I can do unimanually with no problem.
Dr. Mohamed, do you always prefer to use a bimanual techniques?
In such cases, I think it's a mandatory to use bimanual, because I think first of all you are decreasing the time of the surgery, because if you are doing unimanual, still you can do it, but the time of the surgery perhaps is gonna be more. I myself adopted to do bimanual even sometime in doing capsulotomy in case of capsular, fibrosis or advanced capsular fibrosis, and especially after the cases of silicone oil in the eye for a long time. Bimanual also can help a lot even in the anterior chamber, not only in the posterior chamber.
And what's your comment on Dr. Ahmed Bidda? He is an advocate of no tamponade vitrectomy, so it's just leaving such a case on saline. What do you think about his opinion?
Actually, this is an ultimate, a goal for all the retinal surgery. If you can deal with any advanced and complicated surgery and end it without a break, definitely this will be much better.
Yeah. For me, sometimes I find some bleeding post-operative will bother the patient, but they have to wait for some time for the blood to relieve. And also keeping a patient on gas or air helps to tamponade or close the sclerotomy superior. I'm not sure, doctor.
I totally agree with Dr. Mohamed Al. I usually put those patients on air. In my late experience, sometimes we may have bleeding from sclerotomy sites.
I'm bringing this subject because I know Dr. Ahmed is a very proponent of keeping on BSS. Thank you, Dr. Mohamed, very much.
If you allow me, just... Can I have one comment?
Yes, please. Yes, please.
As correctly, Doctor mentioned that we, in this part of the world, we deal with such TRD cases very commonly. So I do exactly the same. There's one tool that I added in management of the TRD that helped me a lot, and it's made by Vortex. It's called articulating curved viscoelastic cannula. So you take it inside and then it comes like a curved manner. You put it in between the plan of the membrane and the retina, and you can inject either PFCL or viscoelastic. It helps reduction of the iatrogenic breaks and the bleeding that can happen and gives you that plane. So in addition to what doctor has done, excellent. I just add that one additional tool, and it had saved me half an hour of time in making all that dissections.
Thank you very much. Although I hate this technique because my fellow did inject viscoelastic under the macula. This is why I stopped doing this.